Good morning, good afternoon, good evening, wherever you are, and welcome to this this is the fourth, I think, now, WHO and Technic webinar series on why gender matters for immunization. The session today is about applying a gender lens to research and even innovation. You can listen to this session in French. To do so, please click the globe icon at the bottom of your Zoom window and select French. And now in French for our francophone audience. Vous pouvez écouter cette session en français. Pour ce faire, cliquez sur l'icône en bas de votre fenêtre Zoom qui est en forme de globe. Et là, choisissez la langue que vous souhaitez. Donc, c'est anglais ou français. You can also watch the slides in French. To do so, click on View option, select Michaela for English or Stephanie for French. So you can switch between English and French. Vous pouvez aussi voir les slides, la présentation en français. Pour ce faire, cliquez sur option de vue qui est en haut de votre fenêtre Zoom. Ça s'appelle plutôt option d'affichage, pardon. Et sélectionnez Michaela pour avoir la présentation en anglais et pour voir la présentation en français, sélectionnez Stéphanie. We'd be happy to know who's with us today, so you can already introduce yourselves in the chat box and tell us your name, where you're from. That would make us happy to somehow meet you. And if you have any question during the presentation, please use the Q&A box. It's available at the bottom of your Zoom window. You can ask your question at any time, and our panelists will answer them after the session, during the Q&A session. Finally, this session is recorded as usual, and we'll share with you the links to the video as well as the slides by email. We hope you'll enjoy this session, and I'll give the floor back to Stephanie. Stephanie, the floor is yours.
Thank you, Alex. And maybe we'll go right to the next slide, please, Michaela. Welcome, everybody. Welcome back. And I hope we have a lot of return attendees today, and welcome to any new attendees. As Alex mentioned, this is the fourth in our series of 5 webinars. And overall, this is actually the second part to an ongoing webinar series. So really, officially, this is the 9th out of 10 webinars that are all based on the Why Gender Matters for Immunization guidance document that was jointly published a couple of years ago by WHO, UNICEF, and Gavi. And so today we're talking about gender lens and research and innovation, but we do have one more remaining webinar in this series. So just a reminder that everyone should be automatically registered for that, but there's still time if you have colleagues or anyone else in your network that's interested to join us for the last session. So do continue to share this onwards with your network and anyone else who might be interested in joining us next time. All of the recordings and materials are available on our dedicated TechNet page. The link is there. We'll share it in the chat, and it'll be available again at the end of this presentation. So for anyone that's missed any of the previous webinars or any of the webinars in the first series, everything's there available online for you to go back and listen to at your leisure. So we'll move right along. Next slide, please. So as I said, this webinar series is based on this guidance document, Why Gender Matters for Immunization. And the guidance document lays out a number of gender-responsive approaches to increasing immunization coverage, each of which has been the topic of one of the webinars in this series so far. We're using this opportunity to take these concepts from the guide and apply them in practice and see from colleagues, country implementation partners, how this is actually being applied in their settings. A lot of the webinars so far have been focusing on programmatic elements and programmatic application of these concepts. Today's is a little bit different. Today we're going to be talking about research and development. And so our content is a little bit more technical, but I find it really interesting. I hope you do too. And the presentations are going to be very rich. So I want to make sure we have enough time to dedicate properly to our speakers. So I'm going to do a really shortened introduction this time and just breeze right through the next couple of slides to move on to our speakers. Next slide, please. So we do have two speakers joining us today, as usual. We have Anna Ruggeri from the Center for Gender-Specific Medicine at the Istituto Superiore di Sanità in Rome, Italy. And we have Sharon Hadari, who is a gender consultant with us in IVB and also to the GRE department within WHO. Next slide, please. So today we're going to be talking about the importance of applying a gender lens to research and innovation. And we know that sex and gender are important determinants of health, and they're critical variables in scientific research, although unfortunately they are too often disregarded, both in study design and also in reporting of the data that's found. So this oversight can significantly compromise study rigor and limit the relevance of the research findings. We're going to have, as I said, two different speakers presenting different aspects of this. So Anna will talk more about the research that she's been involved in and the importance of actually looking at some of these variables, particularly in vaccine immunology research. And then Sharon's going to talk to us more about the overall guidelines that are available in the space to promote better incorporation of sex and gender determinants in in health and science research in general and overall. As usual, in the WHO UNICEF Gavi Why Gender Matters guidance, we do have a little action list that focuses on this particular area, and so that's available for you there. I won't go through that in detail because I want to go right into our speakers, but please do go look at the guide when you have time and read this section for more information and ideas on how this can be incorporated into your work. And so with that, next slide, please. We'll just go right over to Anna to take us through the next set of this presentation. Over to you, Anna.
Hi, thank you. Good afternoon to everybody, and thank you for this kind invitation to give my presentation on sex differences in response to vaccination. Next slide, please. It's known that responses to vaccination can vary across individuals based on several factors, among others, age and sex. Actually, the sex aspect has received more and more attention recently, especially because we have several data providing evidence that sex-specific effect may lead to different outcomes of the vaccination in terms of safety and effectiveness. In this slide is summarized that females, individuals, can have a greater immune response in response to several different vaccination of different age, children, adolescents, adults, and almost always we have higher immune response in females compared to males. Next slide, please. And these sex differences in immune responses is preserved on the evolutionary scale in different animal species, from the simplest one that we can see. Can you click at the, okay, from the simplest one, like sea urchin and insects, reptiles, birds, up to the more complex mammals and humans, always we have greater immune response in females than in males. Next slide, please. And so we can say that women are more immune reactive than men. Next. And however, neither health surveillance programs nor vaccination plans take sex into account. And can you click really all the slide, please? And based on the fact that women are more immune reactive than men, as a consequence, the adverse reactions to vaccinations are more frequent and more severe in female recipients compared to male vaccinees. And next slide, please. This is what is reported by the periodic report of the Italian Agency for Medications, and where this is the last report who refers to the vaccinations in 2021, where we can see that for adults, women report much more adverse events than men. Next slide, please. And for also for COVID-19 vaccination, the Italian Pharmacovigilance Network received much more, like about 70% reports of adverse reaction for women vaccinated compared to men who have like about 30% of report of adverse reaction. And the adverse reaction for female are maintained and are reported for all age groups, and also for severe adverse reaction to COVID vaccine, as well as for mild adverse reaction. As we can see, the red one bar is for severe adverse reaction in women, and the blue one is a severe adverse reaction in men. Next slide. So historically, we know that women have been underrepresented in vaccination trials as well in general clinical trials. And although there is evidence that sex of the recipients have an impact on the immunological response, vaccination are administered to males and females equally, and this could have resulted in women receiving an inadequate dosage of vaccine as well as some drugs. Next. This is what has been reported from a study conducted in US a few years ago, where men and women were vaccinated with different dosages of influenza vaccines, seasonal influenza vaccines. Adult men and women received full doses or half doses of the vaccine. And when adult women were received half dosage of vaccine, they reached same concentration, same level of protective antibodies as men, the blue bar, the first blue bar, as men vaccinated with the full doses. And the adverse reaction were more common and more reported from vaccinated females than male. Next. But which are the mechanisms underlying these sex differences? There are some gender-related mechanisms due to the occupational activities or different lifestyles between men and women, and societal and cultural norms. But I will focus on sex differences, so sex-based mechanisms that are those related to the differences in immune response between men and women, in the hormonal asset of sex steroid hormones, and the chromosomal aspects, so the genetic aspects. Next slide. So reveal all the slide, thank you. So women have stronger innate and acquired immune response than men. Actually, with regard to the innate immune response, there is, among others, stronger production of antimicrobial. Sorry, I can hear someone who is talking. Is that all right? Can you keep the microphone a little? Thank you. So I was saying that the women have a stronger innate immune response than men, like they produce higher level of antimicrobial cytokines like interferon alpha in response to vaccines, and also they have more effective antigen presentation. And with regard to the adaptive immune response, they have higher number of activated T lymphocytes and also increased number of B cells and higher level of circulating antibodies. Next slides. With regard to sex hormones, the sex steroid hormones receptors are present on immune cells, including lymphocytes. So immune response to infection and vaccines can be modulated by the steroid hormones. Actually, estrogen can have a dual effect on the immune system. They can have anti-inflammatory effect in high concentration, and in low concentration they have a pro-inflammatory effect. Progesterone is anti-inflammatory, and testosterone, in addition to have anti-inflammatory effect, is an immune modulant, since testosterone can have immune suppressive and sometimes immune stimulatory effect. Next slide. With regard to the genetic mechanisms underlying the sex differences in response to vaccines, we know that the female cells have a double X chromosome asset, and male cells have one X, one Y chromosome. In order to avoid the harmful effects of expression of gene products encoded on the X chromosome, there is a physiological mechanism of inactivation of one of the X chromosome. That is a random mechanism. And however, this mechanism is incomplete. So about 15% of the X chromosome escape the inactivation. And as a consequence, there is an overexpression of genes encoded on the X chromosome. Now, the encoding potential of the X chromosome is very high because over 1,000 of genes are encoded on the X chromosome, and a substantial number of those genes are associated with the immune response. And so we can understand why females have a greater immune response than males. Next. And how about COVID vaccines? Next. The response to COVID-19 vaccination is affected and is modulated by several factors, by sex, of course, and we will go through this point a little later. And age can affect and modulate the response, since the younger, they have a higher production of a higher level of antibodies in response to COVID vaccine compared to aged people due to the immune senescence of the immune system, but also the previous infection with SARS-CoV-2 virus. It has been reported that individuals who were previously infected with the virus had a higher response to vaccines and compared to individuals who were naive for infection, and also some immune modulating, especially immune suppressive disease and comorbidities. Next. It has been reported in literature that the anti-S response to COVID vaccine is significantly greater in women than in men. Next. We also focused in our lab on evaluating sex differences in healthcare workers, since this population represents a target category for immunization, as they are highly susceptible to contracting the infection and also to transmit infection to vulnerable patients. So we actually evaluated the sex differences in anti-S antibody responses to the 2 doses of mRNA COVID-19 vaccination and tried to identify some sex-specific biomarkers of serologic response to COVID-19 vaccine. Next. Our results showed that the anti-S antibody titers are higher in female healthcare workers compared to males overall. When we consider, you can see here the red bar is for female and the blue one is for male. And this is maintained for all time intervals that we consider, that is 1675 and 145 days post second dose of vaccine, and for all age groups that we analyzed. Next. Then we tried to assess the effect of changes in sex hormones levels in plasma on the anti-S antibody response to vaccine. And we found that on the left side that for estrogens and progesterone, there was no association between plasma level of these hormones and the anti-S antibodies in female and males. But if you look at the right side, we can see that the testosterone was positively associated to the anti-S response. It means that those individuals who had higher levels of testosterone in plasma reached the higher level of anti-S antibody levels upon vaccination. And this association was statistically significant only for men, not for women, suggesting that the testosterone plasma levels could have a rule like indicators of a serologic response to COVID vaccination in male. Next. But the question is, do these sex differences in antibody responses to vaccination impact vaccine effectiveness? Next. Actually, for the COVID-19 vaccines, the results of phase 2 and 3 clinical trials have not revealed any sex differences in the effectiveness of COVID-19 vaccination. Next. Reveal all the slide, thank you. And with regard to the post-marketing studies, currently the sex disaggregated data on effectiveness of COVID-19 vaccines are very scarce and difficult to retrieve, and sometimes the results among different studies are not consistent, since different studies may be evaluate the different outcome of the vaccination effectiveness. Like some studies relate to effectiveness against infection, some others against symptomatic disease, or effectiveness against severe disease. Next. In our country, we conducted a nationwide retrospective population-based study on COVID-19 vaccine effectiveness toward infection and severe disease outcomes during the pandemic period when Delta variant circulation was prevalent. What we found was that vaccine effectiveness against infection was slightly higher in men than in women. Next. But the importance to take sex into account as a biological variable when assessing vaccine efficacy is very well shown in this study conducted to analyze the sex-specific effectiveness of a potential, an experimental subunit vaccine for genital herpes simplex virus infection. This vaccine on the left side, we can see that there show no efficacy in when we consider overall analysis of both sexes, since the vaccinated subjects had did not get prevention of the disease compared to the vaccinees. But when the post-hoc sex stratified analysis was conducted, actually this vaccine was not effective in protecting male, but it was highly protective against genital herpes for female. So since herpes simplex disease is a sexually transmitted disease, the male partners could have benefited indirectly if women had received this vaccination. But actually, this vaccine was not licensed. Next slide. So we can conclude that following vaccination with 2 doses of mRNA COVID-19 vaccine in healthcare workers, women reach and develop higher anti-S antibody levels than men, but they undergo more often to adverse reaction to vaccines, and the adverse reaction in women are more severe than in men. The anti-S titer decreased over time intervals post-vaccination. Next, the experimental evidence suggests that plasma levels of testosterone can be considered possible markers of anti-S response in men vaccinated with mRNA COVID-19 vaccine, but not in women. The sex disaggregated evaluation of vaccine response will help and will contribute to achieve a more appropriate and personalized surveillance system programs in healthcare workers. And actually, the sex-specific analysis of vaccine immunological response, effectiveness, and adverse events in large-scale population studies will contribute to personalized vaccination campaign, but also may play an important role in designing future vaccine trials. So actually, we need more extensive and specific investigation to explain the molecular mechanism mediating these differences and modulating the immune responses to vaccines. Next. Thank you for your attention.
Thank you so much, Anna. Over to you, Shirin. And just a reminder, if anyone has any questions for Anna in the meantime, please put them in the Q&A box, and we'll get to them in the general Q&A session at the end. Over to you, Shirin.
Great. Thank you so much, Stephanie. And, wonderful presentation by Anna, which makes it much easier for me to move forward to discuss why it's really important to address the sex and gender biases in research and help you by applying the SAGER guidelines. Next slide, please. I always like to start with this slide and remind us that we have known for a long time that sex and gender dimensions in research exist. This is an excerpt from an article in The Lancet in 1973, which points to the existing knowledge gaps on sex and gender differences, despite the recognition that they are relevant in all areas of medicine. And more than 50 years later, while our knowledge has certainly advanced in this area, it's still rather the exception than the rule to routinely and systematically consider important sex and gender implications in research. Next, please. And a case in point is COVID-19, a very recent pandemic. And despite knowing from the very early stages that this was a virus and an infection that were experienced differently in women and men, there were differences in risk and experiences of symptoms and outcomes of the COVID-19. Yet these issues were really poorly studied and reported. This is the result of a systematic review that we conducted conducted on clinical studies about COVID-19. And we found that the samples were often not gender balanced, and more importantly, data were rarely reported by sex or analyzed based on sex and gender, as you can see by these findings. Next slide, please. And sadly, this is not only the case in the context of COVID-19 research, this is actually a little bit across the field. So we continue to ignore and disregard research and reporting that overlooks really these important dimensions. Studies are rarely designed with sex and gender in mind and are often not gender balanced. Sex and gender of subjects in the research are often not reported. And if they are reported, outcome data are rarely disaggregated by sex. And finally, importantly, analysis ignores potential sex and gender dimensions, and findings are presented as if they could be applied generally to everybody, which we kind of refer to as overgeneralization. Next slide, please. And in response to these persistent sex and gender biases in research, the Gender Policy Committee of the European Association of Science Editors, which I founded and co-chaired, developed the SAGER guidelines in 2016. Now, it's really important to note that the SAGER guidelines is not an WHO normative guidelines. These are a set of recommendations that are developed by the Gender Policy Committee and is trying to really encourage more systematic reporting of sex and gender dimensions in research. These are recommendations that are targeting researchers, authors, editors, reviewers on how to improve the research and reporting of sex and gender aspects in research. And these researches are applying to all research with human, animals, and any material originating from humans and animals, as well as any other disciplines whose results will be applied to humans, such as mechanics and engineering, and increasingly the artificial intelligence and digital technologies, which are often being used now also in health. And while they were initially developed as a reporting guidelines, these recommendations are applicable across the entire research cycle, from design and protocol development to analysis and reporting. Next slide, please. Now, I will give you a quick overview of the key recommendations of the SAGER guidelines. The SAGER guideline provides some overall and general principles that is more cross-cutting and should be applied across the research. And one is to be mindful about the use of the terms sex and gender in order to avoid confusing both terms. Where the subjects of research comprise organisms capable of differentiating by sex, biological sex, the research should be designed and conducted in a way that can reveal sex-based differences in the results, even these were not initially expected. And similarly, when subjects can be differentiated by gender shaped by social and cultural circumstances, the research should be conducted in a way that can also add this additional level of distinction. Next slide, please. Recommendation 1 and 2 of the SAGER guidelines emphasizes the importance of clear reporting about the study. Recommendation 1 highlights that if a study includes only one sex or gender, this must be clearly stated in the title and abstract. And recommendation number 2 encourages authors to do due diligence and reviewing past studies and literature to examine whether sex and or gender differences could be relevant and expected, and to summarize what we know about potential sex and gender differences or aspects. Next slide, please. And this is an example of a study published in The Lancet in 2019. And we can see that the title and abstract make no mention of whether the study included both women or men. And however, when examining the study demographics later on in the article, we find that more than 80% of the participants were men. And this is a point that could have been important to mention in the abstract of the study. Next slide, please. Recommendation 3 is about the method section. The method section is crucial, as we know that reproducibility is the cornerstone of rigorous science. For any study to be reproducible, it is important to provide clear information about sampling, data collection, analytical methods, and it's also important to detail efforts made to ensure sex and gender balance in research, as well as any reasons or any barriers that resulted in an imbalance or in a particular exclusion of certain groups. In this example, again, I'm just referring to the same study, just it kind of helps you with following through the same article as well, that we can see that both women and men were eligible to be enrolled in this study, yet the study was more successful in recruiting men. But when later on in the methodology section, we note a point around the inclusion of women in childbearing age, which really hints that there might have been potential barriers that could have caused lower participation of women in the study. And I think it's important to bear in mind those when looking at the study, both sampling, recruitment, as well as analysis. Next slide, please. On that note, it's also important to be transparent, clear, and comprehensive about the sources of data and methods to use data on sex and gender, as well as the purpose of the study in order to enhance accuracy, minimize confusion, improve reliability, and allow also for meaningful interpretation. Specifically, it's important to know how was the data on sex collected? Was it about genotyping, examination of reproductive anatomy? Was it about collecting the data on the legally recognized sex in the documentation, or was it self-reported sex assigned at birth? And similarly on the gender, how was the data on gender reported? Was it the self-reported gender? Was it the researcher and provider reported gender, or any other way? So I think that clarity is quite important when reporting on how data have been collected and analyzed. Next slide, please. It's further important to consider also what additional sex or gender relevant data should be collected. It's not always about disaggregation, and disaggregation alone cannot be, it's not always sufficient, and additional relevant data could also be critical as well. And this is, for example, very kind of interesting case in the context of COVID-19 infection and vaccines. No studies actually looked particularly at the impact of both the infection and the vaccine on the menstrual cycle of women, which is an important topic to consider. Whereas after the vaccines were rolled out and in later studies, this was reported, and that I think points out the importance of considering additional sex or gender-related data that needs to be collected throughout some of the clinical studies in particular. Next slide, please. The results section is one of the kind of most important recommendations, that it's important to really provide outcome data, not only demographic data, but outcome data routinely disaggregated by sex, and where appropriate, provide meaningful sex and gender-based analysis, or justify if such an analysis was not possible due to a variety of reasons, including potentially kind of a lack of sufficiently designed sampling in order to allow that. Regardless of that, it's important to provide the raw data by sex and or gender in order to also allow for future pooling and meta-analysis. And in particular, in clinical trials, data on withdrawals, dropouts, and adverse events should be reported disaggregated by sex. Next slide, please. And just to really highlight on that, and again, as articulated by Anna, we know that sex differences exist in both innate and adaptive immune responses, both to self and foreign antigens, resulting in differential immunity and immune responses in women and men, both to infections as well as vaccines. So that is really a critical point for us to consider, specifically in the context of immunology studies and vaccine studies. Next slide, please. Similarly, as Anna mentioned in her presentation, we know that there are differences in adverse reactions to vaccines, and several studies have confirmed that women experience both a higher frequency and a greater severity of vaccine adverse events. And despite these, none of the vaccine studies we reviewed in our systematic review provided adverse event data disaggregated by sex. And we could see that following the vaccine rollout, there were clear differences in experience and types of adverse events of COVID vaccines between women and men. So it's important to consider this already in the research and the data collection and analysis phase, specifically in terms of reporting as well. Next slide, please. And again, just to kind of come back, the importance of reporting the data on clinical trial discontinuation and dropout. And we know that in clinical trials, participants discontinue due to a variety of reasons. Some of them is due to serious adverse events, which might be important to investigate if they are more common among one sex or the other because of biological reasons. But withdrawal can also be influenced by gender-related barriers to participation in clinical trials. For example, feasibility to take part, frequency of visit, timing of visit, interaction with the researchers, issues around childcare or other paid commitments, and so on and so forth. And it's important to consider how clinical trials are organized and operationalized, and do they allow for equitable and equal access and participation by all groups. Next slide, please. And finally, the discussion section should really contextualize the findings within a broader context, highlighting if there was a lack of sex and gender-based analysis, what does it mean? And the presence of a gender imbalances, what are they as the limitations of the study? How could they influence the interpretation of the findings and their applicability to the general public or broader groups? And also highlight additional studies that might be warranted to shed further lights on understanding the sex and gender-based differences or other sex and gender-related factors in the future. So those are really important to elaborate in a discussion section. Next slide, please. Now, SAGE guidelines also provide checklists as tools that can guide authors in preparing their manuscripts. These checklists are also extremely valuable for researchers when they're designing their studies, and they can also be used by reviewers and evaluators when assessing research protocols, funding applications, as well as journal manuscripts. Next slide, please. Since their publications 8 years ago, the SAGE guidelines have now been widely accessed and adopted by leading academic journals and publishers. They are listed in the Equator guidelines as one of the key reporting guidelines, and they have also been translated into multiple languages. So if any of you are interested to translate the guidelines into additional languages, please feel free to do so and reach out, and we'll be happy to collaborate on that. Next slide, please. And as you may know, in December 2023, WHO formally adopted the Sex and Gender Equity in Research Guideline, the SAGE guidelines, as really pointing out that reliable quality evidence is fundamental to WHO's effort and underpinning its commitment to evidence-based normative guideline development, health policies and practices, and promoting health equity and leaving no one behind. So WHO's guideline, the adoption of the guidelines really means that all research and data-driven publications by and in collaboration with WHO across technical areas are encouraged to adhere to the SAGE recommendations. And that also includes routine reporting of disaggregated data and the presentation of sex and gender-based analysis where appropriate. And these guidelines also apply to all WHO workforce, but as well to all the collaborating partners and anyone engaged with WHO in using and producing data and evidence. And the aspiration is really to instigate change across the evidence generation cycle and to be applied in research design, development of protocols, ethical evaluations, data collection, analysis, reporting, and ultimately informing policy and operational decisions. Next slide, please. And finally, again, bringing and bridging the gender evidence gap is a responsibility of all of us. So it's really important that we can harmonize these efforts across the various gatekeeping functions and various roles that we all have in the research and evidence generation ecosystem. So with that, I would like to move to the next slide. And thank you for listening. And I hope that you all will be SAGER champions and implement that in your work in the future. Over to you, Stephanie and Michaela.
Thank you so much, Shirin, and thank you again, Anna. Actually, I'm wondering if just while we're going to the questions, if we can just move back a few slides to Shirin's second to last slide, Michaela, the one around the cycle, because I think that's a really great visual representation of the complexity of this whole space and how some of the points raised early on that make you think, okay, well, obviously we need to be looking at this better, we need to be looking at this more, but and ensuring that all study designs are incorporating these elements. But as Shirin pointed out through some aspects of her presentation, there's lots of layers of complication there and limitations, even when it comes to recruiting subjects for a study. And it really struck me, the slide on the withdrawals and the different reasons for withdrawal, because it echoes a lot of the access and barriers challenges that we talk about when we're talking about access to immunizations and health services in general for women in certain populations. And the same really applies for even access to being able to participate in trials. So it just shows that interventions need to be considered all the way along the research and development cycle in order to be able to improve this system and generate the kind of data that we need to then be able to translate into potentially differential recommendations for what we're doing for vaccination, practically speaking too. So we have a few questions already in the chat, but I hope that people will continue to post. One of the things that was asked early on, and I think Anna flagged that she would like to answer it live. So someone has asked, are there any sex differences that we know of among infants or children in childhood vaccines? Because a lot of the data we're seeing is from adult vaccination, but do we have studies on childhood vaccination as well? Anna.
Actually, the pediatric sex and gender differences in developed countries are very, very rare. We have very few studies because it's very difficult to study pediatrics and children age. But however, there are some evidences reporting the higher immune response for some childhood vaccination that I also show in the first slides of my presentation, with the female infants having higher immune response. But as for safety, as for adverse reactions, it seems that the male children have a more frequent adverse reaction to childhood vaccination compared to females. That is something different from the adults age. But however, we sometimes think that maybe that the sex hormones may have an effect in determining the sex difference in response to vaccination, but actually there are all for sure some other mechanisms that we don't know so far that are involved in childhood response to vaccination.
Thanks, Anna. And that already touched on the response to another question that was posed around, do we have any studies on the adverse events and how those differ among children as well? But one of the points that's interesting to note about the increased adverse events experienced by women, especially when we're talking about adult vaccinations, and we know this for flu, for COVID, how we know that experiencing an adverse event affects your willingness to, take subsequent vaccines. And so I'd be interested to know if you're aware of any research that is actually linking these differences in immune response and adverse events to the behavior and social drivers for uptake on vaccines. And I was initially thinking about this from, from the individual perspective. So, women have greater adverse events, are then maybe less likely to take, a flu vaccine or a COVID vaccine. We know that a lot of health workers, the majority of health workers are women, so that actually can in turn affect the, the uptake of these vaccines, which are actively recommended for healthcare workers specifically to be potentially lower. But one of the questions in the chat that Odette raised about, mothers who experience adverse events for their children, but mothers who experience adverse events for themselves also might be less likely or have concerns about childhood vaccinations as well, because it's an associated response. It's a negative association. And so I don't know if that is being looked at enough. And I don't know if we have any behavioral and social drivers of vaccination colleagues or experts online that might be aware of some studies that are linking these two. But I think that's a potentially interesting area to look at as well. Sharon, are you aware of anything to mention on that?
And not any particular study that has linked those, but there are a number of studies specifically looking at vaccine confidence in vaccine and vaccine acceptability and hesitancy that kind of relates a lot to these topics. Again, a direct link I haven't seen to that, but most of the studies looking at confidence in vaccine or vaccine acceptability or kind of vaccine hesitancy is around clear and reliable information and access to that. We know that there is a lot of misinformation, in particular around the potential risk of fertility. So when you're rolling out a vaccine, when it hasn't looked at these issues in the clinical research, when there are suddenly reports of menstrual cycle disruption that is not clearly communicated as maybe a harmless with temporary disruption that it seemed to be the case, I think that miscommunication or lack of transparent evidence around that can cause a lot of misinformation that can implicate potential confidence in vaccine research and vaccines, as well as influence vaccine uptake and of course vaccine hesitancy. So I think that's a little bit of the discussion that we are also pointing out here, that most of the research, whether in children, whether in kind of looking at clinical trials, whether in vaccine hesitancy or confidence, rarely looking at those issues to understand how both sex and gender can actually have implications into both the development of vaccines and in terms of the higher experience of adverse event in women. Because also, maybe the dosing is not appropriate for women. Maybe the dosing that we are giving for women based on the reference point that we have developed in men is too high of a dose, which results in a greater adverse reaction. So I think there has been one study that has shown that a half a dose, and Anna probably knows this better than I do, the half a dose of influenza vaccine in women gave the equal amount of antibody response that was seen in men with the full dose. So that also shows that we also really need to think through the vaccine studies in a very different ways, and maybe thinking around differential dosing. If a lower dose is kind of sufficient to induce the same immune response, and again, the clinical relevance needs to be, of course, confirmed, do we need to think about those things much more differently? And, of course, that also have implications for men. I said that there is a question if there is the gender issue. The gender is not only about women. Women have been historically overlooked in the research, but looking at the gender lens and the sex lens also kind of opens up opportunities for innovation and tailoring interventions to men's needs as well.
Absolutely. And actually, I was going to ask Anna, so that's a perfect segue to that very question. If you can elaborate at all and maybe let us know if there's any research that you're aware of or within your team or elsewhere that is looking at this issue of differential dosing, and that, if we can get the same immune response from a lesser dose, should we be thinking about that a little bit more? Over to you, Anna.
Yes, I reported a study in US about influenza vaccination with half doses. Actually, it's very difficult for ethical reasons to reproduce this kind of experiments on large scale. So it's very difficult to find some volunteers get vaccinated with a reduced dose of vaccines. But actually, this is a very important point. We should not only disaggregate the data, but we should plan the clinical trials considering different dosages, different delivery way of the vaccines that maybe match with the questions. The next question, there is a question about the delivery of vaccines. Probably different delivery system can work much better in a sex-specific manner. So we don't know. We don't have this kind of study of research so far. We don't have data on this, not enough. So I think that we need to spread our knowledge of what we already have in our hand, also with the retrospective studies. I mean, not planned for getting evidence and demonstrating the difference of response between men and women, but we need to take the message that all of us working in science, in immunology, in any field of sex and gender, we should keep in mind that we have to look at these differences.
Thank you. Yes, very much agree. And part of the encouraging of publishing even the raw data, as Shirin mentioned, because then that can open the door to, potentially going back to existing studies and doing some pooled analysis or things like this that might not have been specifically focused on in the initial studies. So again, all the way across this cycle where we can plug these concepts in and try to encourage more reporting. I think addressed most of the questions sort of even in a tangential manner, since there's been some repetition. I think Anna covered already about the gender determinants, or Shirin covered gender determinants for males as well. We just addressed the differential delivery modalities and how there really needs to be additional research in this space to see about the immune responses that we can get there. There is one question, although this is a bit out of scope of this particular presentation, but just to not ignore it, how can we improve gender equality in children? I'm not sure if you mean, gender equality in general, or, gender equality in access to vaccination, but, just a reminder that we did have another webinar that specifically talked about the importance of sex disaggregation of coverage data, monitoring evaluation program coverage, just to ensure that in fact actually immunization programs are reaching gender equity in delivery of vaccines at least. This is something that is done in a lot of countries, but not everywhere. And we saw, especially during COVID, when we were looking at adult populations, that actually we do sometimes have differences in uptake of vaccines among males and females, whereas we tend to assume that among children we have pretty equal coverage, but that is not necessarily the case everywhere, and it's not necessarily the case in all communities. So it's also another reason why it's important for programs to look at this, just because it is another marker of gender equity and gender equality rather in program delivery. But that's slightly off topic from this, this particular presentation. So if you meant something else by that question, please elaborate in the box. We do have one question more. We always talk about maternal antibody protection. Does vaccination in women have an impact on production of these antibodies? Do Anna or Shirin, do you know the answer to that question? Is that something that's been considered?
If the question is if the maternal antibodies can protect on or modulate the immune response of the children, I think the maternal antibodies are passively transmitted to the children. So I think it covers the very initial period of the life, so just a few months or during the period of breastfeeding. So after that, the immune competence of the infants become to increase, and then it makes its own antibody, its own immune system competent for producing antibodies to the antigens that it encounters during his life. So I think it cannot affect the future of the antibody response to future vaccination. I think no.
Thank you. So we have a few more minutes left in case anybody else has any other questions. Shirin, did you want to add something else?
Stephanie, I could answer. I see that there was a question from Fazil around that this is a technical, not for public, and how can we really make public understand? And I think that's a very good question, because one of the things that I've always envisioned, and I hope that we could also encourage science journalists to apply the SAGE guidelines, because we do have a lot of mainstream journalism around science and science, again, innovations and development, but rarely do they actually keep in mind to evaluate or examine or look with the gender lens on the original study. So when they are reporting that to a mainstreaming and a public, really highlighting whether that study was gender balanced, did they look at gender differences, do we have sufficient knowledge about the safety? And I think it is changing a little bit. I think specifically after the, again, incidents around some of these particular adverse events that we have seen following COVID infection and vaccines, there has been a little bit of a greater awareness of that. But I think similarly, the SAGER guidelines should be applied to kind of any public communication about science. And also awareness of patients. I think patients really are extremely powerful advocates to demanding if there is evidence about the safety, efficacy, or effectiveness of any intervention when they're using it. And I'm trying to kind of apply to that myself. So when I'm going to a doctor asking, is there enough studies to show that this intervention, this medication was equally actually safe or efficacious in women, for instance, which we know often where the data is missing, or during pregnancy or lactation and so on and so on. So we can act as public as well to push for these issues.
Absolutely. And I would also say that that extends to when thinking about, I know a lot of the attendees on this call are more programmatic in the work that they do, but that also includes, health worker training and empowering health workers to be able to have this kind of information to then be able to communicate onward to their patients. And it's part of the whole interpersonal communication, but also just, making people aware of things so that they're also empowered as patients to be asking these kinds of things and having this dialogue with their healthcare providers. So there's lots of opportunities there to be able to communicate things in appropriate and audience appropriate ways.
Yes, I can just add that in
Yes.
our country, in Italy, and in my institute, we at least 2 or 3 times every couple of years, we have a webinar and some like seminars for journalists on gender medicine. So we tried to let them know the science behind sex and gender differences so they can reach everybody and so make it easier, science easier for everybody, but in a correct way. So this could be that, to have a SAGER dissemination with a webinar for journalists. I think that would be very much interested.
Yeah, absolutely.
Absolutely. That's really a best practice that that is luckily being seen in more settings these days, but not everywhere yet. And it's they have such a powerful it's really a powerful opportunity to have them on the right side before Sharon already alluded to the disinformation that can crop up if we don't get ahead of these things and ensure that things are being communicated in a proactive way. It leaves a void that can be filled by less desirable voices, let's say. Okay, so actually, I'm glad we had time to really get a good discussion at the end on this one, because we're going to lose our interpreters and we're also going to lose our speakers right at the hour. Maybe we can close. Alex, did you have any closing remarks just to say? Maybe we'll flip right back to the last slide. Again, all of the recordings of this webinar and the previous webinars will be available on our TechNet landing page. The materials from this and the recording will be sent around by email in the coming days as usual. And in the meantime, if there are any additional questions that you think of afterwards, you're always welcome to put them into the TechNet forum, TechNet discussions, and we can always facilitate the dialogue that way with Anna and Sharon and amongst our other TechNet community members as well. So please do use that as an opportunity. Anything else, Alex?
No, this is great. You said it all. So I think we can close this session.
Well, thank you so much to Alex. Thank you to our interpreters. Thank you, Anna and Sharon. Thank you, Michaela, for organizing this. And we hope to see everybody back in 1 month on July 11th for our last session in this series on vaccination and emergencies. See you all then.
Thank you so much.
Thank you. Bye.
Thank you, everyone. Bye.
Have a good
Thank
day.
you.
Bye.
Bye-bye.